Hello everybody, and welcome to the special webinar on COVID-19 and MSF's work in response to this global pandemic. Thank you so much for joining us today. I'm Vicki Hawkins. I'm the Executive Director of Médecins Sans Frontières, or MSF, in the UK, and I'm joining you today from my home in London, as you can see with the flags behind me. We wanted to hold this webinar today to talk to you about our work in this really unprecedented crisis, and we're so glad that you've made the time to join us. For the first time ever in our history, MSF is working in the UK, supporting a centre providing COVID-19 care to London's homeless community. It's unusual for MSF to be launching activities in high-income settings such as the UK, but it's not completely unprecedented. And as an emergency medical humanitarian organisation, we work where it is needed and where we can have impact. And we're doing so today in more than 70 countries around the world, which are experiencing the impact of COVID-19. So today we're going to talk for about 45 minutes. For the first 30 minutes, the webinar is going to be guided by questions that have been submitted ahead of time by supporters. And for the final 15 minutes, we will take questions that are submitted over the course of the webinar, so please do keep them coming in. If you're watching through Zoom, please submit your questions in the Q&A box. If you're watching on Facebook Live or Twitch, then submit your questions through the comments section. Those will be directed to me, and then I'll ask them to our panelists. So I'll get right to the introductions. So joining me from London today is Dr. Alan Pereira. Alan is a GP from India and has worked with MSF across the world. But today he's currently working as our medical team leader for MSF UK at the centre providing COVID-19 care to London's homeless community. Alan, over to you to say hello.
Hi, everybody. Thanks for the introduction, Vicki. As Vicki said, I'm a doctor from India, and I'm currently working in the UK project that MSF has here. I've had the opportunity to work for MSF in a few countries, starting with India, and then on to Ethiopia, South Sudan, and also during the Ebola crisis in Sierra Leone. I also worked a bit with the emergency teams, so in Syria, Yemen as well, and now I'm here in London as part of COVID-19 response of MSF. Thanks.
Great, thanks Alan, and thank you to you for joining us as well. And joining me from Paris is Dr. Natalie Roberts, who's gallantly stepped in at the last minute to take the place of Daniela Ritsu-Reed, who was going to join us from Bangladesh, but sadly can't because of connection issues, largely driven by the cyclone that has happened in Bangladesh over the last 24 hours or so. Natalie has worked with MSF since 2012, and today she is the Director of Studies at MSF's Reflection Centre. Hi, Natalie. Thank you so much for joining us at the last minute.
Hi.
Do you want to just introduce yourself and say something about your current role and your experience with MSF?
Yeah, absolutely. So yeah, I joined MSF in 2012. I'm an emergency doctor background, and I worked in the field a bit all over the world, really, in emergency projects in Syria, Yemen, Central African Republic. And then the last 3 years, I've been working at our emergency desk here in Paris, managing emergency operations. And particularly last year, I was very much involved in the Ebola epidemic in DRC. And right now, my work within our reflection unit, the Crash, is to examine really the approach, MSF's approach to epidemic responses. We were particularly looking at the Ebola response, actually, and then the COVID pandemic started. So I'm now, at the same time as reflecting on previous experiences, to use that kind of experience to think about our approach to this pandemic today.
Great. Okay, so obviously very pertinent for our topic, and we're really happy that you're with us today. Thanks. So just to dive straight into the questions, so I'm gonna take the first two which have come in, and then hand over to Alan and Natalie to field some of the questions. So the first question that we're taking today is from Emmanuel Uitonze. I'm so sorry, Emmanuel, that I did practice that name beforehand, but I obviously not enough. Emmanuel's question is it really possible for MSF to be able to support COVID-19 patients worldwide? So as we've already said, MSF is working in about 70 countries at the moment. And as the severity of the COVID-19 pandemic was building and the epicenter moving from Asia to Europe to the US, we've largely been preparing ourselves, preparing the facilities that we're working in, but also supporting ministries of health to prepare, because obviously they are going to be bearing the brunt of the COVID-19 pandemic. Wherever we work as MSF, we're never aiming for complete coverage. We're not a Ministry of Health, and we're not trying to substitute for ministries of health. But we are supporting and assisting the most vulnerable. And that vulnerability is often determined by conflict, people living in conflict-affected countries, people who could be displaced by conflict or other reasons, such as increasingly environmental issues, or just generally marginalized and persecuted populations. So our work with COVID-19 will be targeted at those groups. We're also particularly concerned about patients with other health conditions, such as HIV, such as TB. And it's incredibly important for us as well that we focus on keeping existing healthcare services going. And I think this is going to come, there'll be a question on this later, so I'm not going to talk too much about this. But we do know from some of our previous experience in outbreaks, Natalie already referred to the Ebola outbreak of DRC, but also West Africa, 2014, 2015, that more people actually die because they're not able to access healthcare services during an outbreak and pandemic than actually die from the pandemic or outbreak itself. But we'll come on to more of that later. So a second question from Jason Dunnett. What is the current thinking about the medium to long-term impact of the pandemic on MSF's work around the world? In the short term, looming recession and quarantine requirements may impact donations and cause operational challenges. Operational challenges, I can absolutely agree with you. We are facing real challenges today to move people and supplies around. And then the question continues, but could the crisis ultimately lead to greater support for the work that organizations such as MSF do, as more people have had direct experience of disease outbreaks? So Jason, I really like the optimism at the end of your question. And I think that it's true, it could be a consequence of the current situation that globally there is a greater sense of empathy for medical crisis, for humanitarian crisis. People realize that even well-resourced and strong healthcare systems can become overwhelmed. There's also an opportunity in research and development for drugs and for vaccines. Generally, access to vaccines and treatments around the world is not equitable, and particularly if you're living in lower or middle income settings, then often such countries are not able to buy the drugs that could be required to treat particular conditions. There's a lot of attention now to creating more equitable access and to ensuring that vaccines and drugs for COVID-19 as they're developed, that lower and middle countries can access them in an equitable way. And that's really important for us in order to be able to deal with this pandemic, which we need to do on a global level and not just on a national level. But unfortunately, the signs for that have not always been good, and we have seen protectionism in the search for vaccines, richer countries being very protective about their PPE, their personal protective equipment supplies, their PPE. We've also very concerned about the potential closing down of migration and refugee routes under the guise of public health measures. So whilst I always like to see the positive in something, we need to also be very aware that we could continue to see a much more nationalistic and protectionist approach as countries grapple with this pandemic. Okay, so next question is actually from me. So Alan, it would be great if you could just give us a very brief description of the MSF COVID-19 project in London and what your role is there.
Yeah, sure, Vicki. So during this pandemic, it's something that we haven't really seen before. MSF is looking for gaps in the healthcare system, vulnerable populations, and a partnership that rose out of this was here in London, where we work along with UCLH and Thames Reach, which looks after people experiencing homelessness. When people were told to safely isolate, or people with symptoms but who were not sick enough to need hospitalization, we found that there were so many people who did not have this opportunity to. So the hospital or healthcare center that we opened was catering to these needs. So it's people who either were suspected or confirmed to have COVID, but were not sick enough to go into a regular hospital. So what we did was gave them a place to safely isolate while having a medical team to be able to monitor their needs and ensure that if at all they did get sicker, we were able to refer them in a timely way. So that's in essence the project that's been running here, I think from the beginning of April in London.
Okay, that's great, Alan. Thank you for that. Now I'm going to pose you a follow-up question, which has come in from Andrew Dunbar. So it's obviously, as I said at the beginning, it's unusual for MSF to be working in higher income settings, such as the UK, not unprecedented, but unusual. Is it a good use of our resources, do you think, to be involved in the response in the UK?
Yeah, I think that's a really good question. I think what we found is no matter which country in the world and how many resources they have, there's often a population which is left out or which does not have enough access to healthcare in time. And as MSF, we try to fill in these gaps, and that's exactly what we tried to do here, which was not replace systems that were in place, but look out for those, speak and bear witness for those who may not have had opportunity to do that through the regular healthcare system.
Okay, that's great, Alan. Thank you for that explanation. Maybe stepping back a little bit from the UK, although there might be some relevant sort of experience you can draw upon as well for this question. A question from David Shepherd. How do we as MSF go about organising our activities sort of in a joined up way? So ensuring that there's communication and we're coordinating with the services that are being provided by potentially in a setting like Bangladesh, by other aid organizations, by the government, by the Ministry of Health.
Yeah, I think if I look back at many of the projects, actually most of the projects we worked in, MSF's projects end up being in partnership. So it's generally with the Ministry of Health, but often with other organizations or the community. I think the London project's a great example. The MSF medical team came with experience in dealing with outbreaks. University College of London Hospital had experience of the healthcare system here in London, and Thames Reach have been working with people experiencing homelessness in the housing, social aspects of it for a long time as well. So we were able to complement each other to be able to provide a service which probably none of us would have been able just by ourselves.
Okay, great. Thanks, Alan. And I think also that speaks a little bit to the last question as well, perhaps. And given the scale of the outbreak here in the UK, I think we have found that MSF has had some useful experience to bring to the NHS. We've been in dialogue with hospitals and with other sort of groups around the NHS. Bringing some of our experience of working in large-scale outbreaks and sort of keeping activities at an emergency level over a sustained period of time. So the role that we've played in the UK has gone a little bit beyond the particular project that Alan's involved in, but has also been about sharing that experience from our work elsewhere around the world. Maybe now moving on to Natalie. Natalie, can you give us a brief description of the work you've been doing recently, examining the impact of COVID-19 on low and middle-income countries?
Yeah, absolutely. I think what's interesting about the fact that this is a pandemic is that we could also describe it as a whole collection of epidemics actually happening in different places at different times. And at the very beginning, obviously it started in China, moved across to Europe. And at that point, really, our teams working in low and middle income countries where we already see huge problems with accessing healthcare and you know, health implications already, they started to say, well, we don't know what's going to happen where we're working. We don't know how to prepare for this very well. And at the same time, we don't think that there's a one-size-fits-all approach. We don't want to just do what you can do in Europe, because in fact, we'll never be able to do that in the places where we're working. So what came out very, very early on was the messaging that came from China was, you know, you need to have intensive care services, you need to have ventilators. And our team's saying, well, we don't have ventilators. We're not going to be able to build and create intensive care units in a short space of time. So what can we do really to approach this epidemic where we're working? So my role has really been to try and understand a little bit more this disease. It's a new disease for everybody, to understand really how we can approach this disease in any location, and then try and interpret that to the locations where we work. So that looking at the risk factors for people to actually get the disease, looking for the risk factors for people to get severe disease, to try and anticipate, you know, how much we'll have to actually deal with this epidemic. And also something you mentioned before, I think, Vicki, that the response to the epidemic and the fact that health services tend to close down and disease control mechanisms that come in can actually have a more harmful impact than the actual disease itself. So trying to get some balance there and some comprehension from our teams about what is the appropriate measure to take? Are we going too far by closing down some of our activities? Is that going to actually cause more problems than continuing the activities that we have and just allowing, you know, not trying to do anything to stop COVID spreading? And I've just been trying to help facilitate some of those conversations, some of those discussions, having calls with our teams. Last week I spoke to our teams in Bangladesh, in Kenya, in Liberia, to just try and understand what they're seeing on the ground today, actually, and allow them to brainstorm some of those problems.
Great. Okay, thanks, Natalie. So that actually leads on very nicely to the next question, which has come in from Kumar Chandiramani. Sorry, Kumar. How are we going to respond to the ethical choices and the moral dilemmas? And certainly the answer that you've just given points to the fact that this pandemic there's many ethical choices and moral dilemmas that we're being faced with. So how do we manage those, both as an individual practitioner, you as a doctor, in terms of the conversations that you're having with the field teams, but also at an organizational level?
Yeah, I mean, it's a really good question, actually, because it is very complex. There's so much uncertainty. We're working in a disease that we don't know. We've never seen this type of scenario exactly like this happen before. And every day it brings up these individual level kind of dilemmas, actually, because we don't know what the right decision to make is. I think my role in that is really supporting the field to make their individual choices. And then as an organization, to make sure that we demonstrate that support to our practitioners on the ground. They're going to be faced every day with ethical and moral dilemmas. And I think as an organization, we can't kind of say, well, we know how to do this, but what we do is we support you and we'll try and feed you the information that you need, but mainly to feel that you're part of something else, you're part of a bigger sort of organization that is there behind you. So for example, the team in Kenya, in Nairobi, they were talking about how they understand the principle of people being isolated to stop spreading the disease, and for people to be put in quarantine if they're in contact with the disease. But at the same time, what they're seeing is that's making people very afraid. And they don't really think that it's actually the best method to approach this disease, because people are so afraid that they're running away from the police, they're running away from health facilities. And so our teams are now stuck in a slightly moral dilemma of how are we going to make sure that we can provide access to these people to health facilities without making them afraid that we're going to report them to the authorities and they're going to end up being locked up against their wishes, essentially, which is how the population perceives it in Kenya. And I think you have to break down these problems into sort of individual level of actually practically what can they do today for this patient and how can they address these types of problems. And I think once we do it step by step, case by case, then we'll gradually build up a sort of bigger picture and a bigger understanding of our approach. But I think we have to go back to centering it around the individual patients rather than trying to come out with sort of one big organizational approach of this is how we manage COVID around the world.
Okay, all right, thank you. Alan, I'm actually going to direct the next question to you. So you are about to leave for Bangladesh. Bangladesh obviously hosting the largest refugee camp in the world today up in Cox's Bazar with the Rohingya population. So a million people in a sort of very large displaced camp, very crowded, 10 people or so living in small shelters. How on earth can people living in such conditions keep themselves safe from COVID-19? What does MSF's work look like in a setting like that?
Yeah, thanks, Vicki. I think that's a difficult question, but MSF and the community itself are looking at how they can best manage this. Like Natalie just said, isolating or self-quarantine in some of these places is just impossible. Testing is not available yet to be able to know how far it's spread. We do know that there already is COVID in the Rohingya camps, and MSF has set up a few hospitals as well to manage patients who do end up with severe symptoms. So I think in the end, it's all about coordinating and putting these together to make sure that either we decrease or mitigate the impact as much as possible. But it will definitely be a very daunting task, which the teams are facing already.
Okay, all right, thank you. Alan, sticking with you. So there's been some unexpected good news in the media about the positive aspects of housing homeless people in hotels during the pandemic. Any thoughts on how you see this moving forward and contributing to the reduction in homelessness in the future? And that question has come in from Joanna Bacon.
Yeah, I think in our experience, it's a short time that we as MSF have been working with people experiencing homelessness here in London. So it's been about 6 to 8 weeks. I think what we found was that many of homelessness itself was a big reason why people could not access healthcare. If you're every day worried about having a roof over your head, you're not able to think and make other decisions regarding your health. We found that patients who came in to us, we've been able to sort out sometimes long-standing medical issues in addition to the COVID, because they've had a bit of stability during the time here. We've been able to link people to either social services, mental health, their general practitioners, drug and alcohol services, everything else as well. And they're in the process of doing screening for other diseases while patients are with us, and they've consented to do that. So I think homelessness definitely has a huge impact on people's healthcare, and being able to address the issue of homelessness, even albeit for a short time these last months here in the UK, has improved access, and hopefully we'll see the benefits of this in terms of healthcare in the longer term. So I think from a healthcare point of view, we definitely hope that that people are not put back out on the streets, because this has shown that we can actually solve the issue of homelessness. So we are hopeful.
Okay, great. Thanks, Alan. And maybe I just sneak in a quick question from Ali Criado Perez, who's a long-standing MSF field staff member. Might MSF support for homeless COVID-19 extend to out of London? What are the plans for the future?
Yeah. I think I'll say hi to Ali first, because we worked in Nigeria together. I think, like we said, this was a pandemic and an emergency, and that's why MSF intervened at this point. Once the systems in place are able to cope, there probably would not be a need. I think MSF will continue monitoring the situation if number of patients go up or there's a gap that nobody else can fill. But for the moment, there's not larger plans to do large-scale operations in the UK.
Mute. Okay, great. Thanks a lot, Alan. Okay, and then final, a question for Natalie. So how do we, so we've already talked a little bit about the challenges in terms of maintaining pre-existing healthcare services, but the importance of doing so. So a question from Padraig Leons. How do we promote and prioritize care related to COVID-19 without sacrificing the delivery of care and funding to other healthcare programs? Is this realistically possible in resource-poor settings?
I think it is actually. I think what I'm astounded by is the creativity of some of the MSF teams working on this and actually working on these problems. We have some teams that are very invested in their projects. I'm thinking of an example of we have a project in Goma in the DRC that manages an HIV cohort. So the HIV patients in Goma, they're all linked to this project. And quite early on, the team said, well, we want to make sure that this group of people, 3,000 people, they can continue accessing care for their HIV. And some of them are pregnant with HIV, some of them are newly diagnosed, some of them have HIV and tuberculosis. They said, but we also need to not continue the program in the same way that we manage it today, because we don't want to bring them to health facilities and put them at risk of getting COVID. And we also think that maybe they are more at risk of getting COVID. So we need to understand how we're going to manage their pre-existing condition and the fact that they're more at risk of getting COVID, and the fact that they're actually probably more vulnerable as a population than others, because the economic impacts of the epidemic, the social impacts, the negative social consequences of this epidemic might really impact this population because they're particularly vulnerable anyway. So they started thinking a bit more creatively, saying, well, rather than bringing them to the clinic every week or every month as usual, what we'll do is we'll send them away with 3 months supply of their drugs for HIV, but we need to keep in touch with them somehow. And there's a lot of them. So we're developing together with them, I've been working with them on this, to develop a way of using SMS messaging to keep in contact with these patients so that they get automatic SMS questionnaires. They respond, and in that way, at least we're keeping an eye on people. We're starting to understand if they have a problem with their pre-existing condition, and if they're developing any other problems, for example, that they've become symptomatic of COVID, or that they just have a social problem. You know, they don't have enough money to eat. You know, I think the creativity of our teams thinking around it and saying, well, it doesn't mean that we have to divert resources from one thing to another thing. We just have to work out how to manage the health of our patients in a different way, and in a way that does the least harm and ideally the most benefit. I think that's really been, you know, the interesting thing for most of our teams that were already managing cohorts of patients or already managing projects, is they've really incorporated the pandemic and the consequences of the pandemic inside their operations, rather than creating separate operations for COVID. Of course, on top of that, we have created some separate operations for COVID, and we do have to look at the resources that we dedicate to those, because there's one pot of resources. There's a certain limit. There's only a certain number of staff that we have available. There's only a certain budget that we have available. But I think everybody's trying to work together to say, well, how best to use those resources and how best to share them out. And again, with the human resources, there's been quite a lot of creativity. It's not just that there's a limited number of staff that work for MSF. It's the fact that with movement restrictions and things like that, we can't necessarily just send people to a country. So in Yemen today, we're seeing a lot more cases of COVID, but we can't just put people on a plane to arrive there tomorrow. There's a lot more bureaucracy and movement restrictions in place. But what's happened is the staff already working in that country have kind of really come together to work out how best together as a pre-existing team they can balance the way they're working and dedicate the right amount of time to COVID while not sacrificing their other activities.
Great. Okay. Thanks a lot, Natalie. And I think a really nice example there as well of how we're having to use technology as well, which of course, yeah, is exactly what we're doing today as well, in order to try and sort of reach supporters and talk about our work in COVID. So that's something that I think we're all having to adapt to really quickly. I'm just going to, some questions coming in on the chat, so that's great. I'm just going to ask you both a final sort of really personal question, not really personal, a slightly more personal question that has come in from Joanne. Again, apologies for the surname pronunciation, Joanne Pugnies. So you've both worked for emergency teams over your years with MSF. How do you find the energy and resilience to keep going in what must be very difficult and challenging situations? So just a little bit more on the personal side, how you, but keep it short so we can move to the chat questions. Thanks.
Do you want to go first, Natalie?
I can, yeah. I mean, in some ways, I find it easier when I was based on the field. In some ways, because there you take the next problem that's in front of you, and you keep your energy up because you're just dealing with problem by problem by problem, and you don't kind of look in the longer term. Really, you just deal with the challenges you have on that day. And in some ways, I've used to find that a lot easier. Though after about 3 years, it did get a bit tiring. Actually, I think, now that I'm based in Paris, and particularly with the fact that I know I can't just get on a plane and go to places, and having to kind of try and support people on the ground via, technology like this, it's actually quite more tiring, because you feel a little bit frustrated with the fact that you think you could do it yourself, and you just think, explain to somebody what I think they should do, and have I really understood what they're trying to tell me as well. So I think that's actually more tiring, is to be a little bit at distance. But I think the fact that you still have to break it down to, okay, today's challenge is this, and if we can get past that challenge, we'll look at the next one. And in the end, I think that's the way to keep motivated.
I think
and Alan.
Yeah, I think for me, I've been thinking about this, and to me, I feel it's a privilege, because to be able to be with people who need you, or in the greatest time of need probably in their lives, is a privilege that many people don't have. And doing that with people who think like you, that could be, fellow MSFers or humanitarians from all over the world. The feeling when you achieve something together like that is, I haven't felt it anywhere else. Just to give you an example, it was Ebola in Sierra Leone in 2015. I mean, when it started, we all were worried that it would turn out to be something as big as the COVID pandemic now. But then people got together and were able to achieve incredible things. We saw patients getting treated, cured, and leaving the hospital when most people thought they would die. And just feelings like that sometimes keep you going. Yes, there are tough days, but it is a bit of an addiction, and I'm definitely doing it because I still enjoy it, and I don't see it as I'm suffering in any way.
Okay, great. Thanks, Alan. Okay, so now I'm just going to the chat. So Alan, there's a first question for you. Can you describe us a typical day at the homeless care facility?
Yeah. So it varies, but the homeless care facility is it's your regular budget hotel that was converted in 24 hours into a healthcare center. So each patient gets their own room where they can self-isolate, and we have a team that provides them room service. Two types of room service: food, and also on the medical side. So our nursing team goes in, and we divided the hotel into a green zone and then a red zone where we have to wear full personal protective equipment when we go inside. So the medical teams go and check on these patients multiple times a day based on how often they need. We have rounds where we discuss patients, and then there's a lot of linking the different services to a patient to make sure they have comprehensive access to healthcare. So that's how it's been. Now we also field phone calls from emergency rooms who are able to refer suspect or confirmed patients directly to us. Earlier, we were getting patients a lot from the shelters as well. So now our phone rings from emergency rooms and hospitals who are discharging less serious patients but still need a place to self-isolate. So it's a bit varied, but I hope that helps with giving a bit of an idea about what it's like.
Great, thank you, Alan. Okay, so there's two more questions which I think I'll have a go at. So the first question is about support. So at this challenging time, charities and not-for-profit organisations are in need of continued donations and financial support to ensure they are able to continue with their vital work in the future. How is MSF working to increase donations and public support at this time? Very good question. So MSF, many of you probably already know, but MSF is an organization that relies for the vast majority of its support on private donations. So 98% of our income comes from private individuals. So today we have an appeal out for our work in COVID-19 and its wider impact. So we're very grateful to those supporters that have already donated to our appeal. If you would like to donate, then you can go to the URL msf.me/coronavirus, and you'll be directed to your national website, whereby you can donate to support our work directly in COVID-19. But beyond the appeal, for us, a very, very important source of income, a reliable source of income, and it's the kind of income that enables us to respond very quickly in the event of an emergency situation, is monthly donations. So we have regular donors who support us every month, and that kind of support is absolutely vital for our responsiveness and our ability to act fast. So if you're not a monthly donor and you're thinking of becoming one, then please do search on an MSF website, and you can find more details on that. But of course, we are concerned about income over the longer term because of the economic impact that we all know that the COVID-19 pandemic is going to have globally. And the way that MSF really goes about building support is through exactly what we're doing today, is through our staff telling their stories about our work and demonstrating the impact of that. So we will continue to do that, and it's our staff, it's our medical staff who are really the ones who are sort of our best storytellers, if you like, who can really kind of demonstrate firsthand what we do in 70 countries around the world. Another couple of questions come in. So one about why is MSF working in the UK? I'm disappointed my contributions are being used to support work here at the cost of supporting poorer countries. As we've explained already, so MSF, it's not unprecedented for MSF to work in higher income settings. We do exceptionally take the decision to do so where we feel there is a risk of the healthcare system being overwhelmed, particularly as we've seen in Italy, for example, or where we feel there's the possibility that more marginalized groups will fall between the cracks and won't receive the healthcare and the support that they need. And that's the decision that, and the view that we took on contributing to the response here in the UK. Obviously, what we're doing is a very, very small contribution compared to that which the NHS and other groups have mobilized. We felt it was very important in our approach in the UK to work in partnership. We didn't intend to set up MSF operations in the way that we do in Bangladesh, for example, or the country that Alan is about to go to, or the countries that Natalie has been talking about. So we focused on partnerships with pre-existing organizations, St. John's Ambulance as one, and the NHS UCLH as another, basically prioritizing supporting them with staff who were not able at that point to travel to the other countries that we're working in because of the travel restrictions. So we've taken a very low resource, but I think high impact approach to our work here in the UK. Another question has come in to Alan. How many rough sleepers have come through your facility from the temporary accommodations across London? And do we know what the situation is outside London?
Yeah. Unfortunately, I don't have a much bigger view. We've had about about 50 patients who've come through our facility, but that is only patients who have had symptoms of COVID. I know that they've been doing larger scale screening programs in the hostels and the hotels. And the good news is that many of these, the percentage of people who have COVID in these screening programs is quite low, much lower than we've seen in other countries as well. And that perhaps points to in another way to the success of ensuring people who are experiencing homelessness were taken off the streets in time and isolated in protective facilities like this. So we've had, yeah.
Great. All right. Thank you. And then final question, I'm going to pass to Natalie. So social distancing is not possible in so many communities in Africa. What guidance would MSF give to medical services in these countries to keep infection levels as low as possible?
It's a really, really big point, actually. It's something we started looking at very quickly because some of the messaging that happened particularly in Europe, we felt that either it's not applicable in some of the countries we work, including in Africa, or it's just not possible. And one thing I noticed talking to many of our teams actually, were they sort of say, well, yeah, we started at the beginning by spreading the message, telling people that they had to wash their hands and stay home. And then the feedback that they got, and I heard this from the slums of Nairobi, and I also heard this from the camps in Bangladesh, were, well, people stayed home. When they were sick, they couldn't come to the hospital. So in fact, that was a really bad message to pass, and that we need to change the messaging that we have for different populations. Even the messaging walking around, the slums in Nairobi, or I heard in the slums in Manila, the same thing, saying, well, actually you need to wash your hands. And people would reply saying, how can I wash my hands? I don't have soap, I don't have access to water. And in fact, my main problem today is that I don't have enough food. In the slums of Nairobi, there's been a curfew put in place, which means that people can't even necessarily go to work anymore. They can't even earn money to buy food. So trying to kind of put in place the measures that we've put in place in Europe to try and stop the spread of the epidemic, it's not even possible, but it's also probably not ethical to try and impose some of those measures on people. What we looked at instead was kind of thinking, well, what could be effective to try and slow the spread if we do start seeing cases in some of these areas. So when people said, well, they can't wash their hands because they don't have soap, distribute soap. When people say, well, I can't wash my hands because I don't have access to water, we started collaborations. Either we did it ourselves as MSF or collaborate with other organizations to arrange for water points to be set up. We had long discussions about the use of masks. It was a little bit controversial. Do masks work? Do masks not work? And in the end, we decided that we supported the use of masks because actually in some ways it's a sort of symbol of solidarity. That we distribute masks and people wearing masks, we're trying to do something to allow people to protect themselves and protect their families. And the other reason we looked into masks was because actually what we're recommending is these masks are made locally. So people who can no longer work or don't have enough money, there's so many little local seamstresses who will happily start making masks. We give them the resources, we give them the money, and they produce the masks that we distribute, and we're feeding into the local economies. So in many ways, while you can't kind of apply the measures like social distancing or the lockdowns or work from home or some of the other things that we've recommended in Europe, there are different ways of doing it, which we're not sure if they'll be effective, but at least it's a sign for the population that we're trying to do something to help them to protect themselves. And they can think logically about what is this disease, how is it transmitted, and how is it possible for me to try and protect myself and my family while still not, while still being able to work, while still being able to feed my family. And I think that's really been the reflection in pretty much every project we had in lower middle income countries.
All right. Okay. Thanks so much to both of you. Been really fantastic to have you join us and to really hear the sort of first-hand account of the work that we're doing in London. Alan about to leave for Bangladesh, and as you sadly reminded us, there are already COVID-19 cases in the camp. Plus, they've just had a devastating cyclone to deal with. And Natalie from Paris to talk to us about your your work looking at the wider impact as well of the COVID-19 outbreak. Thank you so much. And thanks to all of you who have joined us and for submitting all of your fantastic questions. I'm really sorry we didn't get the chance to address absolutely all of them. But I also know that Daniela, who is going to join us from Bangladesh, she has also offered to answer any questions that were directed at her about our work in the camps there. So we may be able to still get back to you. Thanks to all of you that are online that are currently supporting MSF. As I've already described, as an independent and neutral humanitarian organization, none of what we do would be possible without that private financial support. You really are the people that enable us to do everything that Alan and Natalie have so well described today. If it wasn't for your support, then our work would just not be possible. So big thanks again to those who so kindly donate to us, but also spread the word and talk about the work that we do, because that awareness is so really important. We would love to keep you informed about our work, including our response to the COVID-19 pandemic. We do have a regular email newsletter, so please do sign up for that if you're not already. And if you aren't already, please do consider becoming a monthly donor, or if you would like particularly to give to our work with COVID-19, then to say that URL address again, msf.me/coronavirus, and you'll be directed to your national website. And there you'll be able to find other details about how to support us, how to sign up for our newsletters, and of course you can find us on Twitter, on Facebook, and on YouTube. We really welcome every opportunity that we have to engage with you and to tell us about the work that we do and that you support. I talked earlier about trialing technology, so this is a new initiative for us to be doing a webinar like this from the UK. I really hope that you've enjoyed it and that it has helped us to feel connected, even though we're not able to physically be together. So thank you again for joining, and I hope to see you on a similar event like this. Thank you. Take care and goodbye.